Hello, everyone. Welcome. My name is Claudia Chiriboga. I'm professor of neurology and pediatrics at Columbia University Medical Center in New York and the pediatric MDA care director at my site. Today, I am joined by Dr. James Weimer, who is neurology and professor at the University of Florida in Gainesville, and also the director of the Fixell Motor Neuron Center, which is a multidisciplinary clinic that follows ALS patients, SMA patients, and other motor neuron disorders. Today, we will be discussing the clinical presentation of later-onset SMA in adolescents and adults and the process for making the diagnosis and differential diagnosis considerations. We know that there is a delay in diagnosis with SMA, but it's more obvious in the younger child who has trouble walking because the process proceeds faster. But in older onset SMA, it can be years before it is diagnosed. Case in point, I followed a woman who, in adolescence, her mother thought she was lazy because she had trouble running and became fatigued. And it wasn't until she was in college that she couldn't climb a hill and realized that there was a problem. So there is a big delay, and it's something that should be considered. Oftentimes, there will be orthopedic considerations because of the manner of walking. There can be intorsion of the leg, and the patient results referred to orthopedics. But let's talk about specifics of the gait. And the gait is a proximal weakness, and the differential diagnosis is of other pelvic girdle disorders that we need to consider. And let's take, for example, a 15-year-old girl who sees her primary care physician and is complaining of feeling very tired. When she's walking at the end of the day, she feels tired. Sometimes her legs will give out and she will fall. When she has repetitive activities with her arms, she fatigues. She's trying to build muscle strength because she's not very muscular at the gym, and she is getting nowhere with that activity. So in the differential diagnosis, we would have pelvic girdle weakness of a neuromuscular disorder. So what is helpful will be the reflexes, which should be diminished, but early on they may not be. You would get the CK that may be elevated even in SMA. I found in more of the more active patients, especially someone who's at the gym, that the CK can be somewhat elevated, 500 or 600 and even more. So how do we make the diagnosis and make the differential diagnosis? Well, you can suspect it clinically and order a genetic testing, but sometimes it's not clear. So you will want to do an EMG and see if you can identify if it's a myopathic or a neuropathic disorder, but sometimes the EMG can be normal in SMA type 3. So those are things to take into account, and that's when the genetic testing comes into account. The first thing that I would do, given how fast the SMA gene testing is done, is the SMN1 gene testing. And if that's negative, then I will proceed with a neuromuscular panel if we're not clear which direction to go. And my question to Dr. Weimer is, how does it present in older patients? And if you could give us an example.
Yeah. Thank you, Dr. Chiriboga, because I actually love the example you gave as the first patient that you presented during the introduction, because that's for adults, that can be such a typical presentation that we can see, that the patients will, in an adult, or as you mentioned, even in this 15-year-old, people will think they're just lazy. You mentioned the patients that will be going to the gym and they'll be exercising to try and improve themselves, because the SMA patients are normal otherwise. They're cognitively, they're perfect. They go on and get degrees. So they feel this weakness, they understand it, and they work hard to improve it. So a lot of them, especially the older adults, will be people who are exercising, but just can't quite keep up with others. And that way that you were describing it was perfect for how we're going to see in somebody who's older. Our case too is more of a 40-year-old gentleman, but this could be a 20 or 30-year-old gentleman who's who's presenting, or patient rather, I should say, a 20 or 30-year-old patient that's coming in with this increasing difficulty tripping, walking. There may be bulbar, but as you pointed out, like in the 15-year-old, there may not be. They just may have difficulty, when they're playing softball, running the diamond, and they're just not keeping up, and they're trying to figure out why. And that's what led them to their primary care provider, who then led them to the neurologist. And what we have to do as when we're seeing neurologists, as you said perfectly, is we're trying to sort out, is this a muscle disease? Is this a nerve disease? Where are we headed? Is it proximal? Is it distal? What involvement? ALS becomes in the differential, especially as they get older, but the ALS patients usually have more rapid, they'll talk about a year or two in their onset of it, as opposed to the SMA patients who are going to talk about this lifelong, as you mentioned, in the 15-year-old is going to do it. And that's when we start getting that history of the nerve, we start that it's neuropathic, and the EMG supports it, that I agree, absolutely. That's when we start saying, let's do the genetic testing. And in this day and age, it's easy to get the genetic testing to sort that out, because identifying that helps us so much with treatment.
Absolutely. And I couldn't agree with you more about the ease and the speed with which we can obtain an SMA gene testing, the SMN1, and make a diagnosis, because then we can start offering them treatment, which we didn't have to offer before. And it's a wonderful situation to be, because we now have options to treat, and it's important to diagnose them as quickly as possible, and to think SMA, even though they might not look like SMA, what people typically think of what SMA looks like. There's a paper by Lynn that says there's a 4-year delay in diagnosing SMA type 3, but that's all comers. In the adult SMA onset, this later onset, it is much longer. We're talking 5-10 years sometimes of symptoms before somebody realizes that that's the issue. Perhaps it would be helpful if you would give your most salient features that make you suspect SMA in a patient, that they come through the door, you hear the history, you examine them, and you say, this more likely than not is SMA. Let me check for that, rather than another of the limb-girdle weaknesses.
Yeah, and thank you. That's a really good question, because so many of the patients will present, especially the later adults that are presenting to their primary care or their neurologist, with just a gradually progressive weakness. We will say that's one thing about the SMA, it'll be the gradually progressive. But we will hear about the weakness without a lot of sensory changes, number one, to argue against a neuropathy type of process and more towards a motor neuron or muscle process. And then we look at the pattern of that weakness and the involvement. And do we think it's primarily muscular, where we're seeing the fatigue of weakness, or is it this motor neuron process that we're referring to? When we get to the question for adults, where we're trying to sort out ALS, one of the bigger concerns is going to be the presence of upper motor neuron changes. So if we get spasticity, brisk reflexes, not fatigue-related cramps, but just random cramps that could be signs of that spasticity, that's going to be a little bit of a red flag that it's not an SMA. But if we don't hear that, it leans us towards that lower motor neuron. And then we also have to include the inflammatory neuropathies, the multifocal motor neuropathy, which, as it gets more advanced, it can have a stepwise course, but it can appear symmetric. It's going to be a little more length dependent. It's not going to have the bulbar that SMA would have, but it can be an overlapping syndrome that will come with that. How will we sort those out? Well, as Dr. Charaboga mentioned earlier, in all of our patients, I think you're absolutely right. It's the EMG plays a major role in deciding, are we going forward with that? But the EMG is an extension of the exam. As you pointed out, you can still in a type 3 or 4 get a pretty close to a normal EMG. But a normal EMG will help you with excluding the ALS diagnosis, the multifocal motor neuropathy diagnosis. So it's putting these pieces together. And that's why I think we both would agree, if we're headed down that road, you need to refer to a multidisciplinary center that sees these patients.
Right, and it's not dissimilar in adolescents, in young adults, which I do treat. I think from the gait is quite different. Let's compare the muscular dystrophies from SMA. Typically, there's more hip weakness and Trendelenburg gait, where the hip falls, whereas it's more of a waddling gait with the muscular dystrophy patients. I think fatigue is much more impressive in SMA, and it's part of the phenotype, the fact that at the end of the day, they really are wiped out, which you don't really see so much with muscular dystrophy. And then the CK is very helpful when it's very elevated, and it's not so helpful, or it's normal, which would make you think more likely than not that it is SMA. But again, with the milder limb girdle dystrophies, it may not be very elevated, so that might be tough to manage just on CK alone. But everything else that you've described, and I think CIDP is another thing in younger children that might present with pelvic girdle weakness and might be a little more chronic, but it's a lot faster, as you were talking with ALS, that it's weeks, not years, that you deal with that kind of pelvic girdle weakness. Well, it is time to come to a close, and I wish to thank the faculty and the audience for watching, especially Dr. Weimer for this lively conversation. And you can find out more about the management of patients with later onset SMA in the other short videos in this activity. Thank you very much. Hello and welcome. My name is Claudia Chiraboga. I'm professor of neurology and pediatrics at Columbia University Medical Center in New York and MDA care director at the Pediatric Neuromuscular Center. Today, I am joined by Mr. Hugo Trevino, who's a young adult living with SMA in Chicago, who is a disability specialist at the University of Illinois in Chicago. Welcome, Hugo. Today, we will be discussing the provision of effective support structures for adolescent patients with SMA and how to work with them to facilitate their transition into the adult healthcare system. So there is a big push to transition pediatric patients to adult centers, and that is important because the needs of adults are different than the needs of children. And that transition is oftentimes fraught with problems, but other sites might have an easier time with it. And I explain it. It depends just how much support the centers have. So ideally, the pediatric patient, when they are 15 or so, there should be a dialogue and a discussion of what it will take to transition to the adult, where there's less hand-holding, where they have to take charge of their own care and not be as coddled as we do with children, where we make sure everything gets done, all the appointments are made. But as an adult, you have to take charge of yourself, you have to take charge of your finances, you have to take all these other things in advocating the medical system, which is not always easy. So my question to you, Hugo, is tell me about your experience with the transition and what were the aspects that you found that were helpful and areas that you thought that were more challenging for you.
Yeah, thank you. So I would like to start off by saying that when I was a child, I did not go to a multidisciplinary unit, even though I did have a neurologist, and I also did have an orthopedic doctor, that were both doctors at the same institution. They were both doctors at the Children's Hospital here in Chicago. And so I did feel like I was in good hands. Both doctors were, highly recommended, and they were both specializing in spinal muscular atrophy. But then there was like a little bit of a disconnect with like my pediatrician. That pediatrician was not part, of the children's hospital. And then I also kind of saw physical therapy and occupational therapy outside of the structure as well. Once I was ready to be transitioned, I obviously left the children's hospital. And this is where I saw the big shift in the fact of like how amazing multidisciplinary care can be. When I was transitioned over to the University of Northwestern Memorial Hospital. And that is where I finally was able to be transferred over to this multidisciplinary care, where I went from not only seeing a neurologist and an orthopedic doctor, but I also got to see a cardiologist, a pulmonologist, a psychiatrist, the physical therapy, the occupational therapy. I would be able to kind of see them all within the same visit. And so I found this amazing, especially as an adult, that was going off to college, that was, trying transition, that I had moved away for college. It was nice that when I did come home, I didn't need to schedule, 5 different appointments on 5 different days. I was able to kind of just go to the hospital all in one day, take the day off, and go to the Northwestern and be able to see all my specialists in one. One of the things too is I do highly agree, since the doctors that you had as a child, you do feel like they are more catered to you since they've seen you grow. But I think one of the things too that's very important is for parents to kind of start, maybe how you said, at that age of 15 years old, or maybe even younger, honestly, in my opinion, to start making their children be a lot more involved in their care, maybe keeping a journal if possible. Everyone has a cell phone now if they want to keep a journal on their phone or their notes. Of how they feel that their care, or how they're growing, changes that they're seeing. And also just being able to describe your disability to others. I think that's also a really good practice, because you're going to have to be doing that a lot as an adult. And also just describing things that are painful, things that are not, things that are working, right? So that when you do transition over to adult care, that you are able to continue to describe this, especially from a team that knows you, right? And then another thing that I think would also be good practice is making sure that you're allowing young patients to maybe also start practicing and scheduling their own appointments instead of just having the parents schedule the appointments for them. And my parents kind of did that right from the beginning. Also, while I was away in college, I have to admit there was a point where I was like, I feel fine, I feel amazing, like, life is going great. And I did not see any doctors for maybe like 2 or 3 years. And then after that, it was like, okay, now I'm starting to feel some like lower back pain. Things are changing, things are shifting. And then that's when I was like, okay, I know these introductions were made. Let's go back and, solidify these connections with the multidisciplinary team and get more on like, a schedule and seeing them, whether it's every 6 months, whether it's once a year, depending on your care.
Hugo, you mentioned some communication issues with your PCP. Could you elaborate a little bit about that? Was it between your neurologist and your primary caregiver?
Yeah, so no, so from neurologist, from my pediatric neurologist to my adult neurologist, thankfully that transition was a little bit more seamless, in the fact that they both specialize in spinal muscular atrophy and they both knew about each other. But I think that there was a huge disconnect from my pediatric primary care doctor, in the fact that I had found someone that, not only had they taken interest in me, but they took an interest in my disability, and they knew how to identify certain things. So when I actually started looking for a primary care doctor, I had a doctor that would, like, for example, refuse to talk directly to me and instead was talking to the person who I took with me. That was just like the personal aide during the visit. So that doctor kind of fell off the table. I remember I saw another physician who I had to describe my disability every single time I went in there. And so that also showed me that they weren't taking an interest in what spinal muscular atrophy was. And so I dropped that physician. And so some quick notes that I kind of, started thinking about as I was looking for a primary care doctor. since there wasn't that help of like, what do I look for, right, in a primary care doctor, was someone that, that not only were they going to take interest in me, but that they also were going to take interest in wanting to learn more about spinal muscular atrophy. I wanted to, stay healthy, make sure that my breathing was good. I wanted preventative care, especially if I catch a flu or anything or any respiratory infection. I wanted to make sure that they can be like the first line of defense and referring me to, to some drugs before I'm able to kind of get to my pulmonologist. And then other things too that I also had to do on my end was embracing my disability, getting to know and be able to describe it correctly, making sure that I knew what was, a good ache and what was pains for my disability, and just wanting to think about it as a holistic approach as well, right? Especially since I already had my pulmonologist, my cardiologist, my neurologist at Northwestern, making sure that they were also willing to communicate with those specialists over at Northwestern, no matter where my primary care doctor was. And also just going easy on myself, realizing that self-advocacy wasn't going to happen overnight. But that as long as I had my key points, that and where I was looking for a doctor, to try not to sway away from that, and that I knew that these things would grant me, more independence, as I, went over to adulthood and was trying to find the ideal primary care doctor. And finally, I did end up finding that primary care doctor that was amazing, that, did know a lot about my disability, or that took the initiative to learn about spinal muscular atrophy, since it is a rare disease. Not all primary care doctors are going to know about it. And that should not be a factor of not wanting to see them. I think a factor should be their willingness to learn about your disability.
And the other aspect is, and where I find the biggest issue is sometimes the communication between our pulmonologist and the PCP, because you need to go frequently to have respiratory assessments, and the PCP can do that more readily than the pulmonologist, and they have to have an open channel. And your PCP has to feel comfortable assessing you respiratory wise without saying, well, I don't know anything about SMA, go to the emergency room, because that's not the right approach. And it just adds a lot of burden to you when you're already having difficulty breathing because of a cold and everything else. But the pulmonologist knowledgeable in SMA is key to give you the devices that keep your airway clear and that you can connect to in case you have any acute issue going on. And that's key. In the multidisciplinary clinic that you are now attending, you have ready access to your pulmonologist.
Oh yeah, the now where I am going, I do have at Northwestern, my pulmonologist is amazing. My primary care doctor has spoken to them. That was one of the things too that I wanted to make sure that, not only are they faxing information over, but that they're actually having these talks with each other too, right? That they're picking up the phone and just, talking to them too.
Unfortunately, Hugo, not everybody has such a comprehensive, accessible, multidisciplinary clinic to go by, but they should make every effort to attend, even if it's more sporadic, and have a team of more local clinicians that they can have access to, especially pulmonary, orthopedics, and the like if they need to. But as you already said, even if you just had a handful of the multidisciplinary specialists, you would be in a better place if you could see them all in one visit. In our center, not all specialists are included, but we have identified what we call champions, physicians in different specialties who embrace SMA and who we refer our patients to, who are well versed, even though they're within our center, but we open it up a little bit so that we can have access to the best, even if they're not all able to come to our multidisciplinary clinic, and there's an open line of communication. Wonderful. Well, thank you so much for sharing your experience. I do want to thank the faculty and the audience for watching, and you can find out more about the management of patients with later onset SMA in the other short videos in this activity. And Hugo, thank you very much. I found your experience very illuminating, and I hope our audience does too.
Thank you.
Hello, everyone. My name is Claudia Chiraboga. I'm professor of neurology and pediatrics at Columbia University Medical Center and a member of the SMA Clinical Research Center there. Today, I am joined by Mr. Hugo Trevino, a young adult living with SMA type 3 from Illinois, and Mr. Jim Willison, an adult living with SMA from Ohio. Also joining us is Dr. Lisa Fukusato, who's instructor of clinical physical therapy from the University of Southern California in Los Angeles. Welcome all. Today, we will be discussing how to support patients with SMA in working with their multidisciplinary care team to optimize their quality of life. Before going on further, let me just provide a little bit of background information of what the ideal setting for neuromuscular patients would be, and that is the multidisciplinary clinic, which many centers have, but they're not universally available. But in the ideal setting, it is centers where there are numerous specialists in various disciplines, all pertaining to neuromuscular care, who meet at the same time so that patients with neuromuscular disorders can go to one session where they can see the neurologist, the physical therapist, cardiologist, genetic counseling, sometimes nutritionists, some have social workers in counseling, and a number of specialists that can provide all the care they need in one single visit, which for people with mobility issues can be difficult if you have to provide or obtain this service piecemeal. So before going further, let me just inquire on Hugo and Jim. And Hugo, let's start with you as to how you have seen the benefit or lack thereof with multidisciplinary clinic in the course of your journey with SMA from a younger person to now the young adult that you are.
Sure. Thank you so much. So one of the big differences that I saw from when I was younger was that in elementary school and in high school, physical therapy was kind of built into the program, right, of my schooling. It was provided by my district. But as soon as I graduated and went on to college, this became something that I needed to make sure that I was seeking out along with my multidisciplinary care to make sure that my quality of life was getting good or continuing to stay well. And so I remember when I would see my doctors, my, neurologist or cardiologist, pulmonologist, and I would tell them about certain aches or certain things that were happening, that they were constantly like, okay, let's bring in a physical therapy, have them do a quick little evaluation, and then they would write me a referral so that I can continue to get physical therapy and stop contractures, which that is the main key thing that all adult patients need to realize, that as a disability, as it plateaus, it will continue to progress even slightly. And one of the big things that can affect us are contractures. And so we really need to work with a physical therapist, such as like Dr. Fukusato, to make sure that we're understanding, how is that going to impact us with transfers, right? When someone is helping us get in and out of bed, and also just to help us understand our body, our aches, so that we know what is normal, what's not normal. And so that even if we have limited sessions with a physical therapist, that we are able to have our personal assistants, our personal care assistants be able to assist us in everyday life so that they know the proper placement of, how to hold up our leg, how to do a proper stretch in your arm, how to do proper hip flexors, which are all key areas that do gain contractures.
Well, I'm glad you see the benefit of physical therapy, because so often, especially young men in college, don't see the benefit of engaging in physical therapy, not realizing that spending all their time in a wheelchair will result in contractures in certain postures that will make it difficult to have mobility. So before we go to Dr. Fukusato, Jim, what has your experience been as a younger person? And I know you started with your diagnosis as an adult, and it has progressed a bit more slowly. What has your experience been with physical therapy, multidisciplinary clinics if you had need of those, and how has that evolved over time?
Well, over time is a long time for me. I did my first doctoring in 1977. So I've been battling this disease quite a long time, even before there was a confirmed diagnosis of it. For me, I've always been an athlete, and we enjoyed outdoor sports, hunting, fishing, things like that. So I've always been engaged in physical activities throughout my life. And so when things started to manifest in 77, that's when I went to the gym. I thought, surely if I lift 100 pounds 10 times, that would cure me. Obviously, that's not the case, but I've always maintained a gym membership since then. So for me, physical therapy is important, and I've gone to physical therapists, but I also maintain a gym membership. There are 100 machines where I go, and I use 3 of them. And I'm very careful about how I use those 3. I don't use them the way they're designed. I use them in a way that is beneficial to me, so that my muscles are moved, so that my joints are extended, and so that I don't hurt myself. So for me, being engaged in some type of physical activity not only benefits me from a physical standpoint, but also mental. So it's critically important to stay engaged and stay moving.
Lisa, would you care to comment on these dual approaches to maintaining physical fitness and just engaging with any kind of mobility and strengthening exercises?
Yes, definitely. I think that physical therapy is a great tool, and I'm happy to hear that you both have had positive experiences. For those who may not be coming from an athletic background or perhaps have developed symptoms earlier on, physical therapy can really guide your home exercise program or your gym program as your body is evolving and can maintain your safety in doing activities independently. And additionally, it's important to continue to go to physical therapy periodically throughout the years in order to modify those plans and those home programs that you do have established with your body changes, and to sort of take a preventative approach and sort of slow that progression and make sure that you're safe about it.
One aspect that I find that isn't given a lot of weight, but I think is very important, is the fact that weight gain really interferes with mobility and any kind of response that individuals might have to treatment, even because they're carrying the extra weight. And interestingly enough, a lot of even our GI specialists don't understand that when patients with SMA show their percentile curves, when they are at the 5th percentile is when they have about median amount of fat. So they tend to want to get a higher rate of percentiles in weight, but that just is contributing fat. So keeping patients lean on the lower 5th percentile, let's say, of BMI, allows them to participate for longer periods of time, allows them to interact, and makes it easier for everybody for transitioning, because they will have greater difficulty with mobility and turning and even weight carrying if they carry that extra weight. In your site, does that is that something that is worked on in addition to everything else that we were talking about?
Yes, we have a multidisciplinary team as well, and we have a nutritionist on board. I think that that's a really critical point you make, and we also encourage patients to include that aerobic aspect of training into their program. It's not only about flexibility and contracture prevention or strength maintenance, but also weight maintenance and aerobic health. So aerobic exercise is definitely a critical component of the physical therapy rehabilitation program, and communication with your team members, your neurologist, the nutritionist. As a PT, I advocate for my patients, but we also encourage patients to seek those services themselves.
Any other points that either Hugo or Jim would like to make?
For me, it's staying engaged. It's making sure that you take advantage of opportunities and participate. To me, that's key.
Hugo here. So for me, I think that it's so important to continue to keep a relationship with the physical therapist, because physical therapists, not only will they help you, stay healthy, but they can also be a great source for you to get durable medical equipment, right? Which will also help you like with your lung function. It'll help you with pressure sores. It'll help you like even with like improved hygiene, as well. Like if you're kind of getting active, right? And like moving around, that also reminds you, to like, just, stay like to make sure that you're like showering more, things like that. Like at least, I always, that's another thing too, that I always really helps me so that I'm able to move more freely, and not, have a hard time when personal assistants are helping me. Physical therapy will also help with your bone density. It'll also help with like circulation, digestion. And once again, the biggest thing is preventing contractures. And so, when you're thinking about physical therapy, it's not, I love that Dr. Fukuzawa said that, you have to think about your plan. It's not just something that you're doing once a year or something that you're doing every 5 years when you need a new wheelchair. This relationship should be ongoing to make sure that, you're constantly meeting your needs for different points in your life.
I wish to thank Hugo and Jim for sharing your experience and Dr. Fukusato for her expertise. Thank you all. Wish to thank the audience as well for listening in with us. You can find out more about the management of patients with later onset SMA in the other short videos in this activity. Thanks again to everybody.